Well, hello everyone, and welcome to EllieMD's Live Educational Series. We are so glad that you're here as we continue our mission to help people live healthier, longer lives. At EllieMD, we go beyond telehealth. We're building a community grounded in education, innovation, and personalized care to empower your wellness journey. Today, we're thrilled to welcome Dr. Jason Pencek, a board certified nurse practitioner and chiropractor with deep expertise in both traditional and integrative medicine. Jason Pencek is a board certified nurse practitioner with a strong foundation in both traditional and integrative medicine. He began his career as a registered nurse in 2010 and quickly recognized the limitations of conventional care in addressing chronic health conditions. Driven to offer more comprehensive solutions, he went on to study chiropractic medicine and later earned his nurse practitioner degree to expand his clinical scope. Over the past decade, Jason has trained extensively in regenerative and longevity therapies, including peptide protocols, IV nutrition therapy, hormone optimization, PRF, joint injections, and cellular therapies like stem cell and exosomes. He's been using peptides in practice for over 6 years and now dedicated nearly half of his clinic to GLP-1 based therapies focused on weight loss, metabolic reversal, and long term vitality. Jason's approach blends evidence based innovation with whole person care, helping patients not just heal, but thrive. Jason, thank you so much for being here. Thank you. Thank you.
Thank you. No, I really appreciate being here.
Oh, likewise. Well, thank you for joining our community. Guys, if you don't follow Dr. Jason on Instagram, you have to. His videos are phenomenal. We post them time to time. They're excellent. So be sure to follow him. But Jason, before we get started, why don't you share a little about your history? I mean, you just spoke at a biohacking conference. You're really at the forefront of this movement of regenerative health and longevity. Why don't you tell us a little bit more on your background and share what interested you?
Of course. I saw medicine was a failure pretty much in traditional medicine. I worked at inpatient psych for about 3 to 4 years and realized, regular medicine just wasn't working. So I went back to school, started my chiropractic degree, and realized using my hands and supplements was not going to be enough. So I started pursuing my nurse practitioner degree while I was still in school, and basically started my last year of my chiropractic degree, started my nurse practitioner degree, so I could overlap and then finish my clinicals and be practicing as soon as possible. I got out and realized IV therapy is great. I did it myself every week when I first started. I felt really good. IV therapy is an amazing thing to add to your protocols. Unfortunately, you can't telehealth IVs as of yet. Maybe you can fix that for us. You'll figure that out and somehow figure out how all these people here can get that. But unfortunately, as well good as I felt, it wasn't enough. Stem cells, exosomes, all these therapies, hormones, they're all great. It actually started with my friends joking with me years ago, almost 7 years ago now. I have a group of guy friends. We all work out together, and guys like to razz each other quite a bit. And they kept asking me, when do we get our growth hormone and our steroids? When do we can get jacked? When can we go to the gym just get really big? And that got me thinking, like, what can I do with, I didn't know about growth hormone at the time. I had no idea what growth hormone was. And this is what we're going to be talking about today. And I started researching growth hormone. And the first thing that popped up in Google was growth hormone peptides. It was actually CJC1295 and Ipamorelin. And I was like, what is this? One of my best friends opens up IV clinics, and I reached out to her, told her saw this stuff online, didn't know if she knew about it. And one of her practices in New York actually had been using this stuff in practice for like at least a year. So I got all the resources, information, and just so happens I found one of the first peptide conferences that existed in the United States. Happened to be then like a month after I read all this stuff. So I signed up, went to the first conference, started learning about these things. And first thing I started learning about was really the growth hormone peptides. They were actually massive. So I got really excited in this. The ironic thing is this group of friends I have, we're still friends. And none of them, other than hormones, use them for peptides with me. I still think it's hilarious. They got me into this, and I've been doing peptides for the last 6 years. I started following Dr. Seeds. He's like one of the main people who teaches in the United States. Very smart man. I went to his first conferences, did mentorships with him, and I did masterminds. I started learning more and more. And then about 3 years ago, I decided there wasn't enough information out there. I started posting prolifically on Reddit. and I was posting all the time and answering all the peptide questions that existed. People actually weren't sure, what to think because, I'm a practitioner doing this stuff, and on Reddit, it's kind of a cesspool of people out there, so you never know who to believe. So I switched over to Instagram and started posting reels every day on health and wellness in general, and very peptide heavy and focused. And I just felt like there wasn't enough information on peptides for people out there to educate themselves. So I made it my mission to educate as many people as I can, practitioners and lay people, on health, on wellness, because I just think we are lacking this right now. There's just not people out there talking about all the things that I want to talk about. So that's why I'm here now. I'm super happy to educate the people here and give some information on all the things peptide related, and especially on some of the growth hormone peptides that we have.
Oh, thank you. Thank you. Your services are so needed out there, and you're absolutely right. What I love about your Instagram page is it just breaks it down in layman's terms so that the average person can understand it. And you do a phenomenal job. So thank you. We need more people like you. Thank you
Appreciate that.
for all of us. I know when I initially approached you about tonight's call, I was like, we're going to talk about Tesamorelin and Ipamorelin, and you got so excited.
Mhm.
So let's do it. Let's talk about tesamorelin and ipamorelin. And for all of you guys, you have to stay tuned until the very end of the call. And it all is going to make sense why we're even talking about it. So let's get started. Let's to talk to us. Well, let's start high level.
Yeah.
For people who are just tuning in, what are growth hormones? And then we could slowly break it down. What are peptides? Let's start there. Actually, let's go way up. What are
Okay.
peptides? And then what are growth hormones and so forth?
Yeah. Peptides are what we like to consider, I guess, mini proteins. So I think many of us know what proteins are. The difference between a protein and a peptide is the number of what's called amino acids. Amino acids are the building blocks to make a protein. So basically, anything over 2 amino acids up to roughly 50 would be considered a peptide. These are just signaling molecules. They're going to signal your body to do something. There's peptides for weight loss, such as the GLP-1s that we have now. There's peptides for the immune system. We have peptides for growth. We have recovery peptides such as BPC-157. In fact, we have tanning peptides. My tan is actually a peptide I use to stay tan. There are peptides for pretty much anything you want out there, sleep. And if you name a condition, I probably have a peptide that can be useful for it. So peptides are just signaling molecules. Our body naturally makes a lot of these things. GLP-1s, such as semaglutide, tirzepatide, are naturally originally sourced. We make GLP-1s naturally. These are just a synthetic version of that. Um, and they're just there to nudge the body in certain directions. They're very safe. They have low risks. And again, they're there to signal your body to do something or another thing to improve one system or another. So peptides are just these really awesome things that we have to improve overall health, that are very safe, with really good outcomes that can change the dynamic of the body. In fact, one of the things I love about peptides so much is when I was doing functional medicine, many people that practice functional medicine, we use a lot of supplements in that side, way more than the peptide world. I can take a patient that's seen a functional medicine doctor that's just doing supplements and get them where they want to go in, maybe a month, rather than waiting 6 months of supplements again and again and a bunch of pills. So I really love the peptide side because I get faster results and stronger results than I'd see from just maybe taking supplements. Now,
Can
next,
you tell us what the benefits are? Sorry, as
yeah,
you're,
go ahead.
what the benefits are of taking a peptide versus a synthetic medication that we're used to?
Of
Like,
course.
what's the difference?
They're much safer, right? Most of these things are bad your body naturally makes. For example, the immune one I use called thymosin alpha 1. It is a naturally occurring peptide in our body made in our thymus gland. And that peptide is, prolific in our body. So what happens is as we age, it goes down and we can give it back to people. BPC-157 was originally found as a peptide used for recovery repair. It was originally found in our stomach, and then a synthetic version was made to basically do the same thing. So peptides are very, very, very safe. They are naturally occurring most of the time, and little downside, little risk, and a lot of ability to signal. So instead of being synthetic, when like a drug is, we think of drugs very synthetically and they have all these adverse effects. You have a lot less of that with the peptide medicine in general. There's just less adverse effects. And again, what it's mostly doing is signaling your body to do one thing or another.
That's right. Your body recognizes it and knows what to do with it. So it's beautiful versus the synthetic. Okay, so let's talk about growth hormones. What is that? What does your body need it for? What do they do? Break it down for us.
Yeah, so growth hormone, we all need growth hormone. Here's the thing. Growth hormone starts to decrease after puberty. By the time you hit 30, you're losing about 14 to 15% of growth hormone, like a decade. In fact, when you hit 60, you have about 20% of the growth hormone you had when you were at puberty. Growth hormone does a lot of things. It's going to work on sleep. That's one of the biggest things people report when they lose growth hormone. You get older, your sleep isn't as good. You're going to see improvements in things such as your skin. Vitality comes back in your skin. You get more plump skin. You see improvements in muscle mass with growth hormone. Fat mass goes down. Brain function goes up. You just see across the board, growth hormone is one of those things that as we get older, we lose. And this is part of the aging process. As we lose growth hormone, we just feel worse. I always tell patients using hormones such as estrogen, progesterone, testosterone, maybe thyroid are really great things. But if you haven't added in some kind of growth hormone on top of this as we age, you're missing a giant piece of the puzzle because growth hormone is incredibly necessary. I like to call it the jack of all trades, master of none, because kind of everything gets better, right? If you're seeing, fat loss and muscle gain, better sleep, better brain function, better mood, better energy, better sex drive, it's kind of this well-rounded idea. And you combine this even with using your regular hormones, you get better results. So I tell everyone growth hormone is one of the foundational pillars when I talk to people about their health that you want to help bring up. And so we're always looking at ways to improve growth hormone as we age. You could take growth hormone as it is, just exogenously. There are people taking some supplements to help raise it. Exercise can help raise it. And then we also have the growth hormone peptides, which are really, really fascinating to help improve growth hormone output and work very well.
Okay, so let's talk about supplementing with straight growth hormone. What are the downsides of taking growth hormone versus the growth hormone peptides, which we'll get into?
Yeah, the downside is it's a flat pulse, so just always the same, doesn't do anything, just giving the same amount every day. There's no pulsatile matter to it. So it's not pulsing growth hormone like you naturally do. We naturally have about 7 pulses a day when you're in puberty, and they're big, giant pulses, and then they just go away. One pulse, and it's done. Sleep overnight, you get a giant pulse of growth hormone. So when you take growth hormone, you're just keeping that level just static, which we don't like. Also, it's super physiological, meaning you're going above and beyond what your body is naturally able to do when you give growth hormone. A lot of the research and the reasons why we don't like growth hormone is because it does keep the static level and higher levels than you have been at or could have ever made in your whole life. There is some belief that long-term growth hormone use, if you never come off, can cause problems with your receptors not working as well and make your pituitary potentially not create as much growth hormone if you ever come off. We also worry about long-term growth hormone at super physiological levels. Again, these are levels above what peptides are bringing in. These levels can create things such as organ growth, which is not good. So again, we don't like growth hormone because growth hormone doesn't work the same way as the peptides. Even better is that growth hormone can actually cause insulin resistance in people. This is a problem with growth hormone. We know growth hormone can cause insulin resistance, which is one of the leading causes of metabolic disease right now, which is why people are using GLP-1s. So, we don't want to give you more of a reason to use GLP-1s or have to be on them long term, again, unless you want longevity. But if you use the growth hormone peptides, you actually can reduce insulin sensitivity or increase insulin sensitivity, not reduce it like you do with growth hormone. So growth hormone across the board just is not a thing I use in practice almost ever. When patients ask me about it, I will use it in practice myself, but we're talking, I probably had 5 patients in my career I've used growth hormone on. It's been such a rare thing, but the peptides I will use every day, all day.
Yeah, I definitely don't want a second organ, except unless it's another heart. I don't know. We don't want that. Yes, you're right. So, talk to us about the benefits of growth hormone peptides and name a few that some people know. I know we have Samorelin currently available, and there's Hexamorelin, Ipamorelin. So, maybe talk to us about these classes of growth hormones.
Yeah. So there's a difference between the growth hormone releasing hormone and growth hormone releasing peptides. So ipamorelin is a growth hormone releasing peptide. Tesamorelin, which is one of the best ones out there, is a growth hormone releasing hormone. CJC 1295 is a growth hormone releasing hormone. Sermorelin is growth hormone releasing hormone. The growth hormone releasing hormone, the growth hormone releasing peptides are slightly different. Also, hexarelin is a growth hormone releasing hormone. It's actually very powerful, but the problem with hexarelin is that you can have blowout of the receptors, increases in cortisol, increases in prolactin. We don't want those things. So typically, your top three are going to be Sermorelin, which is the weakest of the three. You have CJC 1295, which is the middle of the three growth hormone releasing hormones. And then you have Tesamorelin, which is the strongest of the three. They all are going to work on improving growth hormone output to varying degrees. Now, what we like about the growth hormone releasing hormones is they can pair well with the growth hormone releasing peptide, which is usually ipamorelin. This is the most common one we use in practice. There's growth hormone, there's GHRP 2 and GHRP 6, which is growth hormone releasing peptide 2 and 6. These also raise prolactin, cortisol, and extreme hunger from them. The reason the peptides increase hunger is the peptides actually work on ghrelin. So ipamorelin works on ghrelin, though it doesn't cause much increase in hunger, which is why it's the one people use the most. There's small increases on hunger, but it works on the ghrelin hormone receptor agonist. So it does have some timing effect to it. So if you're going to use one of these growth hormone releasing peptides, you do have to keep it away from food. You usually want to be an hour after you eat and then 30 minutes after you take it, no food, because again, taking in food will shut down this ghrelin receptor since ghrelin does work on hunger. It's our hunger hormone. So there's a difference between like a tesamorelin, which is a growth hormone releasing hormone, and then the growth hormone releasing peptide ipamorelin. Now, you can pair any of the growth hormone releasing hormones like sermorelin, CJC 1295, and tesamorelin. All of them can be paired with ipamorelin, and they make a synergistic like giant pulse. So we're trying to make the biggest pulse as possible. And when you add these together, you have a very synergistic, kind of improvement. If you were to compare or add, for example, sermorelin, CJC, ipamorelin, or CJC 1295, sorry, and you put two growth hormone releasing hormones together, you wouldn't see much of a pulse difference. The stronger one is going to take over and the weaker one won't really work. So you're just wasting, kind of the injection. So I always tell people if you're going to do anything, you want to use a growth hormone releasing hormone and then add in a growth hormone releasing peptide. That is the best synergistic effect you're going to get by combining these.
Got it. So what would you use as an analogy? So one's the chemical and one's the release valve. Is that
Yeah,
is
yeah, yeah.
that a good
So,
way
so
to think
imagine we're
about it?
driving a car right now, right? And we're in this car, and you have the growth hormone releasing hormone. So it's releasing more growth hormone. Think of that as the gas. We're putting the gas down. But if you hold the brake down and you put the gas down, you're only moving forward so far, right? The car is going to move forward, but it's not going to move forward very far. And you're going to use the growth hormone releasing peptide to release somatostatin. Somatostatin comes off. This basically allows more growth hormone to be released. So if you just take the brake off the car, if I gave you just ipamorelin, the brake comes off, the car slowly moves forward, right? So if we're taking the brake off and we're putting the gas down, we able to get that car to move forward really fast and really far. That's kind of the analogy we
Oh,
try to
what a
do.
great analogy. You guys write that down. That's a really, really good one. I love that. So talk to us about tesamorelin.
Mhm.
Tesamorelin and ipamorelin. You said that they pair really, really well. Tesamorelin's the growth GHRH, growth hormone releasing hormone. Ipamorelin's the GHRP. So talk to us about this pair combo. What makes it
Yeah.
so potent and what are the benefits?
Well, testosterone is the most potent. It is really the best combo that exists in my practice. This is what if people can use it, this is my favorite one to use. It has a large pulse of growth hormone output and raise in what's called IGF-1. So ultimately, what growth hormone is going to turn on is IGF-1 downstream. Growth hormone comes to the pituitary, goes to the liver, and turns on IGF-1. So what we talk about typically is IGF-1 numbers. What's your IGF-1 number by taking a growth hormone releasing hormone or growth hormone releasing peptide or even growth hormone? When you use tesamorelin, you get anywhere between 100 to 250 on IGF-1. If you're taking, for example, CJC 1295, you maybe get to 100 on your IGF-1. And something like sermorelin gets you between 50 and 100. So again, you're going to see improvements in IGF-1 numbers, which is what we really care about. And the tesamorelin has the best pulse of this. Now, again, why we use the growth hormone releasing hormone and the growth hormone releasing peptides is they're pulsatile. They're going to recreate the same pulse that you have. So when you give a tesamorelin sub-Q injection, it's about a 38-minute half-life. It is gone quickly. It is not in the system long. It hits what needs to hit and then leaves. Again, the difference between being on that as opposed to being on growth hormone, which just kind of keeps this maintains this level, we're hitting this pulse up and your body will release more, which is what you want it to do. Tesamorelin is the best of this. It was actually designed for HIV patients that were on the HIV cocktail. And you're on this cocktail, you actually produce a lot of visceral fat, a lot of fat around your abdomen too. So, this company came out with a drug called Ingripta. So that's what technically tesamorelin is. It is on label to help with visceral fat for these HIV patients that are having lipodystrophy, which is basically just fat going on, just increasing fat. And then they found out, hey, it works in everyone. Works across the board at increasing growth hormone. And fortunately, it actually still works as the very best. There are other ones that have come to market, like I said, the CJC 1295 and Sermorelin. These have been studied. They're just not as strong. Testosterone became the top dog in the room. And what we love about it the most is that it doesn't increase prolactin and it doesn't increase cortisol, two big things that can be increased with some of the other growth hormone releasing hormones and peptides in general. So you don't want to have cortisol increase because what does that do? Increase your visceral fat. It's going to lay down more fat. And prolactin is also scary. We don't want more prolactin there. It has a whole host of bad things that we see. So if you can do something to increase your growth hormone, again, this is naturally going to be creating more growth hormone. This is what we love about it. It's naturally producing more. I like to tell people what happens as you age is imagine a fan in the room, right? And if I have this fan in my room and every 5 minutes got louder and louder, you and I can keep talking and eventually we get louder and we get to be louder and louder until finally I need a bullhorn to talk over this fan because it's just so loud I can't speak over it. That is the problem with what happens to growth hormone as we age. The signaling goes down. You lose signaling as you age. So your body can produce as much growth hormone at 18 as it does at 99 if you have the proper signaling. And again, the signaling is just staying the same amount of noise coming in, and it just needs a pulse to kind of bring that back up. So what I really love about the growth hormone releasing hormones and peptides, especially testosterone, is that you get this giant signal to come out and produce more of your own naturally occurring growth hormone. So this is completely natural to what we're doing. The thing that we're doing is basically driving our own production up. So you are making it. The other reason that we like growth hormone releasing peptides and hormones better is that growth hormone has multiple isoforms. So there isn't just one single growth hormone in your body. There's different isoforms of it. When we get just growth hormone given to us and it's exogenous and that's what your doctor's prescribing, you are getting one isoform. When you are pulsing out your own growth hormone, your body's pulsing out different forms of growth hormone, different isoforms, and they do slightly different things. Now, the one that we get and is given, the growth hormone that's given, does typically have kind of the most benefits, but there are benefits to the other isoforms that do exist, which is why we want your body to naturally make your own rather than just give you growth hormone overall. You can actually take tesamorelin, and it's equal to about zero point 0.6 to 1 unit of using a growth hormone. So if anyone that's using growth hormone out there or has used growth hormone, it is equivalent to about 0.6 to 1 unit of being on growth hormone. It is a little bit weaker, of course, but you have much longer benefits and you can stay on it much longer as opposed to being on growth hormone, which I do believe should be pulsed and should be started and stopped.
Jason, this is gold. Thank you. You have a really nice, easy way of breaking this down, and I hope everyone's keeping it. If you're not, just replay this. This is really really good stuff. So you mentioned that it was tesamorelin was initially prescribed to HIV patients who accumulate visceral fat, right? Which is it's dangerous. It's very dangerous. But tell us, okay, so what does that mean? What is that? What I guess everyone wants to know if I take that, what's in it for me? What's going to happen to my body? Let's just break it down in simple terms. What can I notice right away? If I stay on it for long periods of time, we have to cycle this, obviously. What is it going to do for me?
Yeah. Full disclosure, I take testosterone. It's my favorite. I switch between that and IGF-1. I love testosterone. I've used the other growth hormone hormones and peptide mixes. For me personally, it's the best. I will tell you in practice, see the same thing. What are we seeing? Well, visceral fat decreases by about 20%, which is pretty massive. So you see visceral fat levels go down. You see
And
reduction in
how long does
triglycerides.
that take? I'm sorry, how long does
Oh,
it take to get that 20% reduction?
it can be under 6 months. It can take up to 6 months to get that reduction to happen.
Incredible.
So it's not exactly like you're going to see it. It's not like we're taking the testosterone and next month we've lost all the visceral fat. We do see it coming down to like I would tell you, out of all the growth hormone releasing hormones that exist, you see the most visceral fat loss. So people get on, they're like, oh my gosh, I lost all this belly fat. Now, when I first started using testosterone 6 years ago, I was, bright-eyed and bushy-tailed with all the peptides. I wanted to try everything. I wanted to put every patient on testosterone. Oh my God, this is the best that exists. And I was using it inappropriately for my patients that wanted weight loss. Now, I don't want anyone out there thinking tesamorelin, ipamorelin by itself is weight loss. This is just not what it's going to be used for ultimately. You still need, this is when I use GLP-1s. They come in and my Sema and my Terza work great. They pair super well with this because you're seeing that visceral fat loss, but 20% visceral fat is not 20% weight loss. This is a giant difference people need to understand. You will lose visceral fat. You will have a decrease in and usually typically people see their abdomen fat go down. But when you're talking about losing 20, 30, 40, 80 pounds, 20% visceral fat loss won't make much of a difference. You won't see anything with this. So this is meant to be paired with other things. If you're already on the right track and pushing your body in the right direction, this is just one more lever you can use to pull. Again, one of the first things you start seeing is deep sleep improvements. You
Wait, wait,
get,
wait. Before we go there,
of
sorry, Jason, not to cut you off. Can you go back to the visceral fat?
course,
What purpose does visceral
of
fat for?
course, yeah,
Just new to all this. Let's break it
yeah,
down.
yeah, yeah.
At
I
the
got it
basics.
excited
What
here.
does visceral fat do? Why is it dangerous? Why is it unhealthy? Let's
Yeah.
talk about that. What are the benefits of testosterone in reducing visceral fat? But let's talk about visceral fat for a moment.
Yeah, yeah. Visceral fat's like really that kind of stubborn abdominal fat. Visceral fat also surrounds your organs. Visceral fat's around your pancreas. If you reduce visceral fat around your pancreas, you can reduce type 2 diabetes. If you reduce visceral fat in your heart, you can reduce cardiometabolic things happen to you. Cardiovascular disease goes down. Insulin resistance goes up, so you're able to handle better blood sugars. So visceral fat is basically the fat around your organs, which is not good. We don't want fat around anything in our body. Low fat is too low fat is bad, but a lot of excess fat over your organs, not a good thing. They have all sorts of things, increased, cardiovascular disease, increased risk of type 2 diabetes. You can see problems with your blood vessels as well because you can get fat around these. Basically, any excess fat that we have that's around our organs is going to be dangerous long term. So you can have improvements in longevity by reducing your visceral fat levels, which again is one of the big things and the biggest thing probably that we see with using tesamorelin.
That's awesome. Thank you for explaining that. Okay, so let's continue. You said benefit number two. So first one, reduction in visceral fat. Benefit number two, you were talking about deep sleep. That's something
Yeah,
we
deep sleep. You get better, deep, restorative sleep, right? As we age, I think, especially the perimenopausal women out there, understand sleep is a major, major issue. Perimenopausal, the menopausal women have a hard time falling asleep, staying asleep. This is typically hormonally related. And I will tell you right now, testosterone does improve this significantly. It's one of the top things I tell patients. And if you get better sleep, everything works better across the board, all the parts of your body. Sleep is a number one thing that's non-negotiable for me. Sleep, exercise, nutrition, those are like the top three things I'm looking at. And if your sleep isn't good, you aren't feeling good. So we see better, deep, restorative sleep, which comes from using testosterone, which is, again, one of the big reasons I use it. Typically, we use testosterone at night because it does repeat the same kind of pulse tone nature that your body does when you have an overnight injection of it. So when you do this at night, you have that giant pulse at night, which helps you stay asleep way better and keep that good quality sleep. So again, that is one of my biggest things. I can't say enough. Anyone that wants to improve sleep, wants to improve performance, I am saying testosterone is the best thing out there for it. It's my first starting point. For anyone that has sleep problems that have already optimized with their sex hormones, the next thing I'm really looking at is your growth hormone. If we can fix that, usually that's fixing most of the sleep problems I have for patients after hormones are optimized.
All right, so wonderful. We got fat reduction, we got deep sleep. Anything else we could expect while we're
Oh
on this?
yeah, oh yeah, lots of stuff. For all people out there right now, look, I love GLP-1s, but one of the issues everyone worries about with the GLP-1s exist is how much muscle am I going to lose? Every single person that gets on a GLP-1, that's the number one thing people obviously complain about. Hey, I'm going to lose my muscle mass. You get on testosterone, you're going to hold that muscle mass. You can go into a calorie deficit and still hold muscle mass on testosterone. It is really, really big for that. If you want to improve your muscle mass and you want to help improve basically how much growth you have, using tesamorelin in mixed with ipamorelin is going to do a great, great job. Um, Basically, what we want to do is keep people's muscle up as they get older. And as we age, muscle mass tends to go down. This is just a known fact. And if we can hold these numbers this muscle mass the best we can. This is what growth hormone's for. As we get older, growth hormone goes down, we lose muscle mass, sarcopenia sets in, which is a loss of muscle. And I will tell you, growth hormone, by using testosterone, is one of the best things you can do other than optimizing hormones to improve this muscle mass output. So if you're looking for a way to hold muscle mass, especially if you're on a GLP-1 and you are very worried about this muscle loss, Tesamorelin and Ipamorelin is going to be much stronger than Sermorelin at holding that muscle and potentially even building some as you're going down.
Okay, so that's great if you're pairing this with the GLP-1s. How about if you're trying to optimize, if you're in the gym, you're working out, you're a bodybuilder
Yeah.
perhaps? How does this help?
Again, like I said, I'm on it. I work out twice a day, and my testosterone and epinephrine really does help me hold my muscle mass, build more, and allows me to recover even better. So again, that's part of that sleep and then also the muscle building. So what testosterone is doing again turns on growth hormone, then goes and turns on IGF-1. IGF-1 is basically the best anabolic peptide that we have in our body. IGF-1 is a uh, anabolic, it's a peptide. It's insulin like growth factor 1. This is what we ultimately are trying to turn on. IGF-1 is really known for increasing muscle mass and strength. So if you're out there and you're just a normal person, you're trying to optimize, you want to have better health overall, you can improve the muscle mass, you can improve that time in the gym. You go into the gym, I can't see the results. I'm spending, an hour, 4 days a week there. I can't see anything improving. If you add in tesamorelin and ipamorelin, you're optimizing the body to have a better production output. Again, like I said, you are losing growth hormone as you get older. The ability to make it goes down. So you hit your 40s and you're somewhere between 40 to 50% reduced in how much growth hormone is being output. That's going to affect how much muscle mass you can put on ultimately. So if you want to get back to the ability to put on muscle mass, growth hormone peptides such as testosterone and ipamorelin are going to be a really, really good option for that.
Okay, I have a question for you. Do men and women respond differently to this, or is it the same for both of us? What can we expect as women versus men?
Um, yes, so men and women do respond equally. The dosing is the same for both men and women. I use the same dosing in both sexes. I will say one of the adverse effects that people get is sometimes you can hold water weight. It's worse with sermorelin. It's the best with testosterone. So the least amount of water weight comes with testosterone and ipamorelin being a combo. So I do see that. But that is one thing that I do tell women and men. Obviously, my men care about strength and recovery and sleep, and not that they don't care about bloating. My women have a much more sensitive, feeling to it. Women in general, you are very sensitive to your body. You understand your bodies very well. My men, it either works or doesn't work. With women, there's a big gray area. Hey, this is kind of helping here, but it's not really helping here. I can see this improvement. I can't see this. Men, it works. It doesn't work. That's ultimately how it is. So my women have a little more to say with it. And I will say my women have told me there's more bloating. Now my men have the exact same response. It's not that they don't see the bloating, but they don't care as much because like, oh, my muscle mass has gone up so much, my strength has gone up so much that a little bit of bloating doesn't really matter to me. I would put this akin to creatine. So the amount of water weight you're going to pull in with creatine, you're going to have even less water weight with using testosterone. So if you've tried creatine before, a lot of women have tried creatine. It's great for building muscles and energy. If you've tried that, you will probably have less water weight than you've seen with that. So if you stop that for water weight, you'll have less of that on the test run, which seems to be the big thing that people kind of notice is that bloating. And again, it is in a small population of people, but it is the one thing I think that women come to me the most to complain about.
Okay, so if you start gaining some weight and the scale starts going up, don't worry, it's just a little bit of water weight.
Correct.
Is there anything that you can do to reduce the water retention? Do you dose down or do you just take a diuretic? What would you
Yeah,
recommend?
let's take another drug to fix the drug we give. I would not choose that option. No, don't get me wrong. I have chosen that option before for patients. For patients like, no, I want to be honest, I refuse to come off. I'll give them a diuretic. That's not something I'm against giving. Usually, I'll give something hydrochlorothiazide if they want it to improve their water retention. That has worked. I'll dose down. I'll dose less frequently. Again, those patients I might switch to Sermorelin because maybe Sermorelin does less of that water. It's very just because Sermorelin isn't as strong. I mean, it still has more water retention. Actually, I think that it has more retention than Tesamorelin. I do see patients that still do better, maybe if they're on one growth hormone peptide or a growth hormone releasing hormone as to the other. I've had patients, again, Tesamorelin is by far in the studies, lots of studies on it, is the strongest that exists. And I have patients still come to me and say, I like Sermorelin better. So it just because it is the strongest out there and the data all supports this, it doesn't mean someone might do better with another growth hormone releasing hormone. If they're seeing bloating here, maybe they'll switch. I think someone just asked me yesterday, "Hey, I'm bloating on this Sermorelin stuff. What do I do?" I'm like, "Well, try Tesamorelin. Like, go to the next one because there might be a better, out body might handle this better and might have less of that water retention." Again, if someone does even diuretics, I will use it. I don't like to. Usually, I'll dose down first, reduce the dose, and then if that's not enough, they still want to be on it. I will give them a diuretic, but it is something I don't like to do unless I absolutely have to, and people want to be on it.
Okay, so let's go back to the benefits because everyone
Okay.
like, what's in it for me? What
Yeah.
can I notice? So, does age matter? Does it matter if you're younger, older?
Mm.
Is there a difference that you'll notice if you're a little bit older versus younger?
I have patients in the 20s on this and they feel great. I have patients in their 30s and they feel great. 40s, 50s, it doesn't matter what age you are. I will say, obviously, based on the fact you lose more growth hormone as you age, you probably will feel better if you're older, right? If you're over 60 and you're making 10% of the growth hormone you did when you were 18, yeah, you're probably going to feel good when you get some growth hormone back. Probably better than the person that's 23 and using this stuff right now. In fact, I've used it as young as teenagers, people trying to improve their growth hormone output to get taller. So I use testosterone across all age populations, and I can't say specifically that a 33-year-old would be saying the same things as a 73-year-old. I mean, they will both say, I feel much better overall. It's not like the 33-year-old saying, I'm already producing enough. I don't notice the difference. I will see across the board people saying they feel better, and across the board people saying it doesn't work. It's kind of that's not age specific for me seeing that. Now, again, based on the studies and the data, I would expect you to be 40s, 50s, 60s and saying, yes, I feel great. Typically 40s and above, I'm saying you should be on some kind of growth hormone releasing hormone and some kind of growth hormone releasing peptide because, again, these numbers we do know go down as we age. So, yes, there is a kind of idea that as we age, we do need more of this. Now, again, what else do we see here? Again, we talked about sleep, we talked about fat loss, we talked about muscle gain. Skin improves. We're seeing better skin tone, hydration in the skin. So your skin looks more full and plump. Like it's improving skin in general. I can tell you your skin gets a little smoother when you add growth hormone back. So it is improving your skin quality. We see improvements in sexual function. You want to improve your libido? I would say testosterone's a great thing. Again, it's going to be stronger than Sermorelin and improving all these things. So you have to come across the board and look at this and say, we have growth hormone release hormones. You guys have LEMD has Sermorelin right now. Whatever you're getting from that, just think of significantly more output of the same things. It's just going to work much, much better than what you're already potentially using. People come to me all the time. They're on Sermorelin. I'm like, oh, we should really get you something stronger because Sermorelin, again, is the weakest of all this. So again, you see sexual function improve. You'll see mood improve. I have patients coming back, less anxiety, less depression when they're taking any kind of growth hormone releasing hormone or peptides. So that's an improvement I see. And it's again stronger being on testosterone. And then of course, more energy, right? People, as we get older, one of the things we all say, we want more energy. Almost everyone out there says, I want more energy. And because it actually works on the growth hormone pituitary axis and can help improve your thyroid as well. So you see better improvements from thyroid as well. So we do see across the board improvements in energy on patients who get on tesamorelin. So there is no doubt that if you haven't considered trying tesamorelin yet, it's the top dog in the room when it comes to the increasing growth hormone, and we're doing it naturally, and we're doing it for something that can be sustainable. So the best part about this is it's sustainable, right? Who wants to get on something and be on something for a month and they feel great and have to stop? When we get on something and it's working for us, we want to be on something long term if we can. So I can't tell people enough, hey, I'm a big believer of testosterone, and I do like to use it long term in patients because when we do prescribe it, we use it either 5 on, 2 off, or 6 on, 1 off. So you're giving your body the ability to have a rest, get the receptors a rest. So we can, and if I ever do actually cycle this, I'll cycle between tesamorelin and sermorelin. So maybe I'm
Hmm.
doing tesamorelin for 5 months and giving the receptors a break and switching to sermorelin. So we're still getting that like kind of break in things. And then I'll go back to my tesamorelin. So there's still able to use it long term with slight breaks. Look, there's no research showing that giving your receptors a break by going from sermorelin to tesamorelin or to CJC1295 is useful. It just isn't in the data right now. But we do believe because of the receptors they work on, it might be beneficial to switch between these two at some point. I would tell you in practice, do I switch people between Tesamorelin and Sermorelin often? Almost never. Almost never unless someone asks me. And I've had people on Tesamorelin for 5 years solidly. So I do use Tesamorelin long term. It is in the studies long term. Again, in the AIDS patients that we put this on, that had the HIV patients that were used on this, it was meant to be long term. They're on these drugs long term. They're going to be taking Tesamorelin long term, nonstop. And if they're talking about doing this in studies, for me, I feel very safe using it long term in patients because it's been studied and looked at, and people have been taking it for long term without cycling off. So Tesamorelin to me just has so many benefits. Again, in the Tesamorelin and Ipamorelin, I keep saying Tesamorelin because that's like the big heavy mover, but we also have to remember again that brake pad coming off, right? We want to get that pulse as high as possible. And when you add that Ipamorelin there, it just shoots that pulse way up. So that doesn't stop that pulse from going up further. It allows it to go as far as it wants to go without having to be stopped and blunted by somatostatin holding down and keeping the release of growth hormone as high as it should be.
Okay, like this sounds like a dream. So you get visceral fat loss, you get better skin, you get better sleep, you get better sexual function, cognitive, like it just everything improves. How fast can you expect results? So if I get
Yeah.
on this today, should I see improvement in my sleep within instantly or within days?
Yeah.
How long?
Yeah, and let me, one thing I forgot, I didn't even really get to mention to you is it does work so well in cognitive function. This is one of the big things we see. Growth hormone turns on IGF-1, which turns on BDNF, which is brain-derived neurotrophic factor. And increasing BDNF increases synapses and ability to form more memories and have better just cognitive function in general. So your brain is going to work better. There is some research showing in people that have the ApoE4 gene, this can be really useful at reducing the risk of Alzheimer's disease and could even be useful in patients with Alzheimer's disease and having issues with memory as they decline. So again, if you have any memory stuff and you want to improve your memory, Teshmon is the way to go. Now, I'm going to go back to this. I just totally lost your question there. I
How
got so
long?
excited.
I'm just so excited for this. I really am. How long should
How
you,
long?
yeah,
Yeah.
before you get
Um,
results?
yeah, so the best thing about testosterone compared to any of the growth hormone releasing hormones, 30 days. In 30 days, you'll see the max output of IGF-1. So it is quick, it is fast. I get to see results. I'll tell patients, hey, if you've been on this for a month and a half and you have no results, it's not the right thing for you. This isn't something you have to be on for 6 months to see if you see an improvement. This is pretty quick. Usually within the first week, 2 weeks, you see sleep improvements. Already trying to see sleep improved. By weeks between 4 and 6, you're starting to see some visceral fat go down. You're starting to see some fat improvements. You start seeing cognitive function in that first month improve. Your sex drive is going to start improving that first month. All the things I'm saying in the first month, you should see basically all these benefits. And they just continue, right? You don't lose all the visceral fat like we said at once. It's just take months to happen. So you kind of see these improvements happen. They keep going. And you keep feeling this way again long term.
Oh gosh, this is great. And now side effects. This is too good to be true. What
Yeah.
side effects can we expect?
Yeah. The water retention, it's a thing. Some people, ipamorelin can cause some hunger increase. So people will say they're incredibly for, well, they get hungry, and then typically the hunger is coming from ipamorelin. Again, it's a ghrelin agonist, so some people do notice this. This is why when I am using tesamorelin and ipamorelin patients, if they're on a GLP-1, again, they're trying for weight loss and they have any hunger increase, it's obviously not the right. Like I'm going to go back to sermorelin, which has almost no hunger increase because also it doesn't work as well. So I'll go back and give them something. But Tesamorelin and Ipamorelin has a small hunger increase, very small number of people. It's not everyone, it's very limited. You have that water retention, which is the big one. One of the contraindications I would tell people if we're not going to use in cancer patients, any growth hormone across the board, if there's cancer growing, we don't want to give something that might grow up more. Now, the caveat to that is if you've taken Tesamorelin and Ipamorelin, there are some backstops that can stop cancer from growing. So for people that are worried about growing cancer from being on these things, from like causing cancer, it's not going to cause cancer. It's going to stop the cancer from actually occurring. So
You,
if somehow cancer gets past and invades our immune system and starts growing uncontrollably, unfortunately, yes, a growth hormone, any growth hormone you do is not going to improve it. It'll probably make it grow more. But if you don't have cancer, again, you can potentially stop any cancer growth that might occur. So I really do like it for patients because, again, the risks are very low in general. Some people get a little hot flash with it, which is a common side effect. Some people have an increased heart rate with the on. Again, this is all done immediately. You do an injection, you have a quick hot flash, you might have your heart rate increase, and then it just goes back down. I will say the only other time that patients have to worry is if they have an allergic reaction to it. And again, it can cause anaphylaxis. It can happen with any growth hormone releasing hormone, growth hormone releasing peptide. So if you do an injection, you get a hive at the site, big, red, really, really, itchy. That's a histamine reaction. And in those patients, if they've taken a growth hormone releasing hormone, any of them can cause this. Sermorelin, CJC 1295, Tesamorelin, all of them you can get an allergy to at some point, and you can cross-react to either one of any of them. So if you've been in Sermorelin and you've had a reaction to that, potentially you might react to Tesamorelin. We don't know that, but it is a potential. So the allergy, potential anaphylaxis, if you continue not paying attention to your body, continue doing injections, each one of these immune responses can get worse and worse. I can't say that anyone do an injection have a straight anaphylaxis in all the patients I've done growth hormone on, but the other thing is an allergy to the actual testosterone.
Oh, Jason, the cat's out of the hat. Yes, huge news, everyone. If you just opened up your email, you should see that we have now announced the launch of Tesamorelin and Ipamorelin. So, Jason, Dr. Jason, you are announcing this big news with us. It is now available to our brand partners for the next 2 weeks before we launch it to the public. So, if you are a brand partner, this is available to you right now, so check your email with instructions. This is super exciting. I mean, I'm so glad that you're here to announce this with us, and thank you for talking about the side effects. Is there anything else that we should know about this? Do you have any last words? Anything else you'd like to add about this? And also, let's talk about cycling. So you mentioned being on this. Do we have to cycle on and off like 2 months, get off of it for a couple weeks, and then get back on?
My patients, I don't do that. I do the 5 on or 6 on, 1 off. So I believe what LEMD is going to be doing, we're going to be doing 5 on, 2 off, which is enough time for the receptors to reset and then restart again. So no, you don't have to do that. Same thing as when I use something like PT 141. I technically can use that daily in patients. And I do 5 on, 2 off. I cycle that way, or I cycle for a month on, then take time off. So you can run testosterone nonstop for the month if you want to, but then you have to cycle at some point. It does not mean you have to cycle off for a month. Maybe take a week off if you're doing a full 4 weeks on, and then take a week off. So there's multiple ways to kind of work this, but I don't cycle on my patients. We just keep them on. I will. Again, when patients ask me, should I cycle to Sermorelin? If they ever ask me, like, sure, we can cycle on to that. If they're asking that question, they're clearly curious if they should try it. And I'll put them on Sermorelin for a month and then go back to Tesamorelin. Again, there's no actual evidence showing that that kind of cycling is necessary, but it wouldn't hurt anyone. People stay on Tesamorelin long term, Tesamorelin and Ipamorelin, as long as that cycling and that 5 on, 2 off, you do allow receptors to reset over the weekend or whatever 2 days you choose, and then you get to go back on it and can maintain it as long as you actually want. Again, these levels are just going down, and we're trying the best we can to maintain or hold or at least bring up from if they were 60 and we almost had none. We want to bring it back up and then keep that age and that age appropriate growth hormone as long as we possibly can without being, again, the big thing is super physiological. We don't want to use growth hormone because it's super physiological and putting you in IGF-1 numbers you would never be at, which is what the problem with growth hormone is: static and higher than it should be. The pulsatile form of the growth hormone releasing hormones and peptides, what makes them super amazing, and the ability to use them long term.
Now, I just want to answer some of the questions that had been coming in. So, Jen asked, does it help specifically with REM sleep or just deep sleep? That's a good question.
More deep sleep. You can have more deep sleep improved. Yeah, it's not REM sleep would not be improved as much. That's more of like a for women and men. Progesterone would be more of what I use for that.
Got it. And someone asked, can I notice side effects like joint pain? I guess she gets it with Sermorelin.
Yep. I might know who that is. Someone asked me yesterday the same question. Sermorelin does increase that joint pain, and again, it's the same idea. You're getting joint pain from the swelling, right? The water retention you have is causing that joint to swell a little bit. Testosterone is less likely to cause that. So for anyone that's getting some kind of bloating or joint swelling, they might be better at switching to a different growth hormone releasing hormone. And that goes, by the way, if testosterone is causing it for you, it doesn't mean that sermorelin is going to do the same thing. So I do tell people this one may not be the right one for you. This is why we have multiple options when it comes to medicine. Sermorelin might be the better option. Again, it is uncommon. I see that, but I do see people doing better with tesamorelin over sermorelin in general, and you potentially might have less of that joint swelling, I guess water retention, which causes that joint to be a little more painful.
Okay. And does this pair well with NAD or BPC, or does this
Of
pair well?
course, yes, everything pairs well with PPC and NAD. My protocol and stack is BPC 157. I run Tesamorelin, Ipamorelin, or IGF-1 is the two I go through back and forth to raise my growth hormone levels and IGF-1 levels. And I'll use NAD on top of this. So I'll put someone on BPC 157. I mean, put them on NAD if I can. I always like to tell my patients there comes a point that if this is all free, right? You pay $0, treatment fatigue kicks in. So we always want to know what works, which is why I pair things separately for patients because I want them to see what's working. If I want to put you on Tesamorelin and Ipamorelin for the next 5, 10, 15, 20 years, you better know why it's working. If I pair that with NAD, NAD helps energy. NAD helps a lot of these things. It can help improve your fat levels. Fat oxidation gets better. Skin can improve. Immune system can improve. That's the thing I missed. I missed out on saying immune system improves by being on Tesamorelin and Ipamorelin. We missed that whole boat. And recovery repair improves. That's what BPC does. I like to say that tesamorelin, ipamorelin, growth hormone in general is going to cover pretty much every base you can imagine. And then each one of these other things we add for peptides are just going to add a bigger layer to that. So yeah, you have recovery pair is a big thing to you. I always want to start with tesamorelin ipamorelin is your foundation to fix growth hormone. That's like honestly should be your foundation. Sermorelin, tesamorelin, foundational peptide. And then pairing in BP157. Now, if you've injured yourself, you have an injury, BP157 right away, sure, great, use it at that moment. But if you're like, I want my recovery better, if you haven't tried tesamorelin and ipamorelin, you're missing out on that one because that might be enough and get all the other benefits that you might want. The BPC only covers that recovery side. And NAD covers energy. It's great. Energy can better, cognitive function can better. Well, ultimately, if you fix your growth hormone, you potentially might have all those things as well and might work even better. And then you can add the NAD on top of that. So for me, again, foundational is fixing thyroid, fixing sex hormones, adding in growth hormone, then pairing in other things on top of it. Until I've done those things, I typically don't want to do anything else with patients. I will try NAD. Listen, you're the one talking to me. This is your care. I want anyone that's out there to understand, like you are the one running the show. I don't care who you are in this today in the Zoom. You run the care. It's your care. We're just here as practitioners and educators to help guide you with what might work the best with you. So here are the recommendations. You might say, screw his recommendations. I want my NAD right now. Fine. That's totally fine. Understand these things all do work and they work synergistically. BP757, NAD, even all the other peptides, they all do pair well with this. But I do love NAD. It's a big one. I would take NAD with this all day, every day. I think NAD is the key to vitality and should be any peptide protocol, even though it's technically B vitamin that we have out there. So.
Yeah, I know we're almost due at time, but so if I have 50 pounds plus to lose, would you recommend that first I get on the GLP-1s, use that for several, or should I get on both at the same time? What would you recommend?
Yeah, I would never recommend starting testosterone ipamorelin with your GLP-1. Again, if there is any hunger change and you're on GLP-1, I can't imagine how many angry people want messaging me say, I got on this stuff and I'm still hungry. If I had testosterone ipamorelin and someone's messaging me, I'm like, oh God, I might be that. I don't know. It's not working for you, right? So you want to try I always would say do the GLP-1 first. Start losing the weight, start seeing where that goes. Maybe 2 months in, you've lost 5, 10 pounds. We see improvements, add in testosterone ipamorelin then. Because if it does change hunger, you won't know if it happened, maybe the GLP-1 either isn't working for you, it's the wrong GLP-1, maybe you need a higher dose. Lots of things might go with the GLP-1, and if you add testosterone ipamorelin too soon, you're of course going to have this major problem where again hunger goes up and you're going to be cursing someone's name up and down that told you to do this together. So don't let that be me. It's not be me telling you that. I'm going to say do them separately for sure. Use testosterone ipamorelin, but do it after GLP-1. I mean, I am giving out GLP-1s like candy to my patients. I think they work for everything under the sun. And then I'm adding tesamorelin and ipamorelin. That is like, peak. Again, I can't say enough. If you've been on sermorelin and you haven't tried tesamorelin, you are missing out because this is the best of the best. The patients I put on this, they're like, I'm ripped. I'm starting to see my abs more because now you've lost all that weight. They're down where they want to be and they're adding that next step in. They're like, I can get way more out of what I'm doing right now. My strength is better. My recovery is better. My sleep is better. I mean, they can't even understand. Now they look at sermorelin saying, did this even do anything for me? I couldn't tell a difference being on that. And then I get on this tesamorelin and it's like, mind-blowing.
I
So,
love it. I love it. I definitely didn't notice a change in my hunger levels when I started Tesamorelin. I've been
did you?
using.
Okay.
Yeah, and I'm one of the few that did have an allergic reaction to it. Is there, and I just kind of like waited out. Oh well, maybe
There's things we
live.
can
Is
do.
there anything I could do, or if anybody else?
There are things you can do. You have to have access to peptides like thymosin alpha 1. Unfortunately, thymosin alpha 1 can potentially clear that out if you're seeing allergic reaction. I would tell you this. Some people get a mild reaction and that's never more. They'll just get this mild little hive. If it ever starts spreading, and I see people getting hives across their whole body, right? You do an injection, and it's a hive at the site and now somewhere else in the body, that's an automatic. You got to stop because the next step is straight anaphylaxis, breathing goes down. And we don't want anyone in the ER because they did a test injection to live longer and feel better. So I would say if you get to that point, again, hive, seeing just a single hive at the site doesn't bother me as much as if the hive gets worse, right? If you've seen the hive spread, it becomes massively bigger. I've injected different peptides and gotten hives before from the way I inject, the angle I do, and I keep taking them and I'm still fine. So I will say the hive is not like an automatic, like one hive and I'm done. I want to see multiple hives and also want to see it get worse. It's getting worse each time. If you're saying every time I get the same hive, it's the same thing every single time, I'm not nearly as worried about it. But yeah, I can't say the hunger increase is a too bad thing because I most patients won't have hunger increase. Again, that ipamorelin can potentially cause it, but again, the benefit of adding that ipamorelin is you get that huge spike. So, it's like hit or miss, right? Do we add that back in or do we not? So,
Well, it's good for me because I forget to eat throughout the day. So it's a nice little reminder to go get some food, get some protein. But thank you so much. I don't know about you guys, this was so helpful. And there's so many questions we still haven't addressed or answered. So that just means you have to come back and educate us. And
for sure,
this
for
was
sure.
awesome. One of my favorite educational series because you just break it down and it's simple to understand and digest. So thank you on behalf of our community. Thank you so much. I mean, I think we had 250, 260 people plus on this call, and I'm sure we'll get tons of replays. Guys, we'll share this video. Be sure to share it with as many people as possible. Dr. Jason, where can we find you? If we want to get in contact with you, where's the best place that we could reach you?
Yeah, my Instagram is at Dr. period Jason Pencek. I do have a TikTok that I don't use, which is Dr. Thirst Trap. It
We gotta
was
find that one.
it was made years ago by a patient of mine who thought it was hilarious, and I have probably posted 15 videos. My stuff doesn't translate well to TikTok, unfortunately, so I would post on Instagram every single day. So every day I have a new post if people want to come learn some stuff.
Well, that's
Yesterday was actually
awesome.
Tesamorelin and Ipamorelin, so this was my post yesterday.
Oh, well, thank you, thank you, thank you. I hope you can come back and educate us some more. And we love this. I love this. Thank you.
Awesome.
And for the rest of you, please go check your emails because it's out. We've got Tesamorelin and Ipamorelin available to all of you, all 50 states, and there's more information on the site. So be sure to check it out. And thank you again for tuning in. Thank you, Dr. Jason. Thank you, thank you. Have
Have
a
a good one. Thank you so much.
thank you. Have a beautiful rest of your day. Mwah. Thank you all.